Hello, my name's Olivia O'Hara. I'm a PMHNP student at Herzing University, and I will be presenting about methamphetamine abuse. So, brief introduction about methamphetamine. It's also known as meth. It's a highly addictive CNS stimulant. The chemistry behind it is dextroamphetamine and levomethamphetamine. It comes in several forms, such as powder, pills, and what's known as crystal meth. And there are also several methods of use, so users can either smoke, snort, inject, or orally ingest it. There's actually some medical use for meth. It can be a second-line treatment for ADHD as well as obesity. So the history of meth abuse started back in the 1800s. Well, in the late 1800s to the early 1900s is when meth was first synthesized from amphetamines. And then in the 1930s to the 1940s, it was introduced to the United States as a treatment for asthma, narcolepsy, as well as obesity. In World War II, soldiers actually used meth to stay awake and alert for combat, which I found quite interesting. And this was also when there was the first epidemic of meth abuse. Japanese kamikaze pilots, as well as factory workers, were reportedly high on meth at that time. And then in the 50s and 60s, legally manufactured meth tablets were abused by college students, truck drivers, and housewives again to stay awake, as it's a stimulant. And then this is also when injectable meth became available for use, and that form was highly abused. And then in the 1970s was when the Controlled Substances Act of 1970 was passed, and that's when meth was classified as a Schedule II drug. Then in the 1980s, meth abuse continued to increase. Mexican cartels were supplying ephedrine to the western U.S., which is an ingredient to make meth. And this is when we started to see the homemade meth labs popping up in the western U.S. especially. Then in the 1990s to 2000s is when the crystal meth epidemic was really prevalent in the western and rural parts of the U.S., and currently we're just seeing higher potency of meth, and unfortunately it's often laced with fentanyl. So the prevalence and epidemiology in the U.S., overdose deaths have more than doubled from 2016 to 2019, and then past year meth use in adults 26 and older increased 60%, so 1.1 million to 1.7 million users from 2016 to 2019. Meth use disorder increased 33% in that same 26 and older group, and then 50% of meth-related overdose also involved opioids. And then meth is often used with or instead of opioids, increasing the overdose risk. So some risk factors for meth use include individual factors like loneliness, mental illness, history of violence. There's an inverse relationship between religion and meth use, and then socioeconomic status as well. Other risk factors include family disputes, addiction in parents, and influence from friends and peers. And just vulnerable populations include those who are uninsured, who rely on Medicaid, those with low income, lower educational attainment, as well as substandard living conditions. So some short-term side effects of meth use are those typical CNS stimulant type of side effects, such as increased energy, alertness, euphoria, agitation, decreased appetite, tachycardia, hypertension, increased body temp, violent, bizarre, erratic behaviors, hallucinations, as well as seizures. And then long-term side effects can include heart and brain blood vessel damage, as well as lung, liver, and kidney damage. And then continued hypertension can lead to stroke, MI, or death. And then also severe tooth degeneration can occur. Those who snort meth can get destruction of soft tissues in the nose. Those who smoke it can see some respiratory issues, and those who inject it can get infectious diseases such as cellulitis or abscesses. Long-term effects also include weight loss and malnutrition, disorientation, apathy, confusion, exhaustion, severe dependence, psychosis, depression, as well as brain structure damage that can mimic disorders such as Alzheimer's disease, epilepsy, or even stroke. And then, so signs and symptoms and effects of meth use include, like I said, the typical CNS stimulant type of effects. So euphoria, increased energy, hyperactivity, and restlessness, especially when it's smoked or snorted. And then the psychomotor agitation during use, and then the psychomotor retardation during withdrawal. Sympathetic signs can include dilated pupils, tachycardia, hypertension, nausea and vomiting. It can also cause some meth-induced psychosis, so like paranoia, hallucinations, especially auditory and tactile hallucinations, as well as confusion. And then behavioral changes you might see upon assessment include talkativeness, irritability, impulsivity, paranoia, and grandiosity. You'll also see some neurocognitive decline, so issues with memory, attention, and executive functioning deficits. And then chronic use can cause what is called a burnout. And burnout, it consists of neuroinflammation, neurotoxicity, and dopaminergic neurons, as well as axonal degeneration. So a lot of brain destruction with meth use. Withdrawal upon assessment, you might see some fatigue, low mood, vivid dreams, sleep or appetite changes, bradycardia, anhedonia, or even SI, suicidation. You might also see some oral health damage known as meth mouth. So meth users often experience tooth decay, gum disease, or mouth sores. And then you might also see some compulsive behaviors such as skin picking, scratching, and these might mimic some of the OCD symptoms that you're familiar with. So overdose and suicide risk for meth use. Overdose users have described the term overamping as instead of overdosing on meth. And it's basically where the body shuts down and goes to sleep. That's how users have described or defined ODing on meth. An article actually interviewed meth users, and several of the users reported that it's impossible to OD on meth. And actually 83% of meth-related deaths involved other substances. So fatal acute meth overdose is actually rare. If there is a death, it's more likely due to the cumulative effects of meth, such as the cardiac or cerebrovascular diseases or the psychiatric complications associated with meth use, or of course if the meth is laced with another substance such as fentanyl. Suicide risk of meth use. It includes meth-induced psychosis and depression that can increase the risk of suicide. So it's kind of an indirect way of increasing suicide. And then acute withdrawal can also cause some SI as well. Let's see. So a treatment or a care plan for a meth user typically would not involve medications. There are no FDA-approved meds for meth use disorder currently. However, studies are being conducted, and bupropion and naltrexone show some promising results, but it's not FDA approved, and there are no FDA approved medications for meth use disorder. The gold standard for meth use disorder is are behavioral therapies such as contingency management, which is a system that provides patient monetary rewards for clean drug tests. So if a patient comes in and their drug test is negative, they can receive some sort of like monetary voucher. Other behavioral therapies include cognitive behavior therapy, CBT, the matrix model, which involves several types of psychotherapy, including family therapy. There's also the 12-step therapy, as well as a mobile app called the Reset app. Patient education should include long-term consequences of meth use. You should really talk to your patients about, how meth is affecting the brain, the body, all the risks associated with it. Patient education should also include harm reduction. So, providing resources for clean needle programs, and then offering or supplying naloxone or Narcan, especially since so much of the meth is being laced with opioids. And then also educating the patient on coping skills and stress reduction, because meth can often be used as a way to self-medicate, and there's often an underlying problem, like mentally. So it's really important to encourage our patients to build and identify those coping skills and practice them and use them when a stressful event occurs, and not turn to meth, and have healthy coping skills instead. Referral should be to either some sort of residential rehab or an intensive outpatient program where the patient can be closely monitored and, kind of followed, and making sure that they're following through with their treatment. And then follow up, monitor for relapse. It might be wise to check in on the patient maybe weekly at first, and then address any mental health concerns that might come up alongside of it. So in conclusion, as probably most of us have seen, meth is a growing problem in the U.S., several parts of the U.S. I live in Colorado Springs, and I definitely see it a lot here. It results in devastating psychological and physical effects. It really is a problem, and it causes lots of problems for users. Treatment consists of a multidisciplinary, collaborative approach. As providers, as future NPs, we must be able to recognize the signs and symptoms, so that we can catch it early and treat it early, and hopefully, try to get these people off of meth. And then long-term recovery support is essential to maintain sobriety, and to make sure the patient is receiving all the support that they need. And that's all I have. These are my references I've used. I hope you enjoyed my presentation. Thank you so much.